these are the people who actually are here. So please, thank you so much.
It's not moving. Thank you so much, Dr. Maria. It was a pleasure when you and Dr. Rajasekharan invited me to give this prestigious IOACON meeting lecture, the eponymous lecture, named after the stalwart Dr. A.K. Saha. I would also like to take this opportunity to thank Dr. Sanjay Chaturvedi, organizing secretary, for all his help with the arrangements to get here. As you know, and especially those who reside in India, that Dr. Amulya Kumar Saha, 1913 to 1994, was an outstanding orthopedic surgeon, clinician, and scientist of his times. He received his degree in medicine from R.G. Carr Medical College, Calcutta. He was in the British Indian Army in the Second World War as a surgical specialist with a fellowship of Royal College of Surgeons of London and Edinburgh a long time ago. He then returned to India and became professor and head of the Department of Surgery at the University of Calcutta from 1955 to 1963. As you can see, his works, his honors, his interests are boundless. He was a Hunterian professor of Royal College of Surgeons, England, founder member of orthopedic section of ASI, president of IAO back in 1969, an emeritus member of SICOT, a fellow of World Orthopedic Concern, innovator, scientist, teacher, who popularized orthopedic surgery amongst young upcoming surgeons. He authored and published extensively innumerable book chapters and articles in prestigious national and international orthopedic journals. His special interests were investigations and understanding of the shoulder mechanism, surgery in post-polio residual paralysis, and spinal surgery. Dr. Saha conducted extensive studies on the functional anatomy of the shoulder joint from anatomic, anthropologic, morphologic, radiologic, and electromyographic as well as mathematical points of view. His paper, as cited here on zero position of glenohumeral joint, its recognition and clinical importance, was incorporated in clinical orthopedic and related research in 1983 as a classic study. This is the hospital where I work. We are at HSS, Hospital for Special Surgery, only doing orthopedics, musculoskeletal, nothing else. Have just submitted our work on shoulder pathology to the AJSM Sports Medicine Journal and the AOSSM Awards Committee, entitled The Bicipital Tunnel, Expanding Our Understanding of Biceps Tail Tendinitis and Associated Pathology, submitted by our fellow Taylor and senior author O'Brien. This is an anatomic and histologic evaluation of a newly recognized and clinical relevant entity, and I hope to report back to you that the article has been accepted, and hopefully we'll receive the award because I think it's groundbreaking bit of work that we have done. Now coming to Hospital for Special Surgery, we at the moment have 85 orthopedic surgeons. We do about 25,000 surgical procedures a year, 8,000 joint replacements a year, primarily hips and knees, but anything, ankle, elbow, shoulder, and about 300,000 patient visits. This distinguished audience does not need the definition of arthroplasty, but it is a surgery to deal with pain, disability of an arthritic joint, whether it's osteoarthritis, degenerative, or inflammatory arthritis such as RA, psoriasis, etc. Foreign materials have been introduced by orthopedic surgeons for a long time in human body for damage and from inflammation, and I would just like to show you very quickly pictorially what it all looks like. Here is the Gore-Tex, and you can see that there are these thread-like spaces lined by foreign body giant cells. So again, the body is reacting against this foreign material that has been introduced iatrogenically. Colograph, ligamentous reconstruction that you do all the time, and here microscopically it looks like this. You see this eosinophilic material, acellular, again a lot of foreign body giant cell reaction. Bone wax for stoppage of bleeding. This is a regular hematoxylin eosin slide. You see that there is this amorphous acellular material. When you polarize it, this is what bone wax looks like. And finally, I want to show you injection of Synvisc supplement. It is, I don't know what's happening here, but in my country, in United States, this is being injected too frequently. And as I speak, we are about to start a major project to study the various forms of viscous supplements, because the surgeon and the pain management people think that this is very innocuous. You should give 1, 2, 3 injections every 1 or 2 months, 1 or 2 weeks, but I think it is causing tremendous havoc. And here I would like to demonstrate to you histologically that here is this amorphous material, this blue acellular material, but see the tremendous amount of foreign body giant cell reaction, chronic inflammation, and in fact, just recently I saw a case not only just involving the synovium, but it was in the bone marrow. So we have talked to 1 or 2 companies, we are pulling out all our cases. I have collected about 100 cases in the last 2 years, where it has been documented pathologically that it evokes so much of response, and we are going to look at this and hopefully do a scientific publication. So as we know that joint prosthesis, usually in the large joints, metal on the convex side and high density polyethylene on the concave side, you use polymethyl methacrylate as a fixator. Now instead of barium sulfate, a lot of it has been replaced by zirconium. And now, as all of you here also must be using non-cemented porous metallic prosthesis to promote ingrowth of bone and fibrous tissue. The cause of failure of prosthetic implant, I think you surgeons know quite well, so this is just a schematic drawing. But just to put it very simply, you get implant wear that is resulted into particulate debris, resulting into osteolysis and failure, like in this region up here. The materials used, as you very well know, are cross-linked polyethylene, metallic alloys, ceramic, like about 10 years ago, metal on metal and ceramic on ceramic. So, what is pathology of revision arthroplasty? This is study of the retrieved bone and soft tissue to demonstrate the extent and amount of implant debris, its size, shape, and surface characteristics, its tissue response, whether it's histiocytic, foreign body giant cells, or plasma cells, and finally also to include cytologic and toxic effects in the soft tissue and metal ions in blood. What are the complications of joint replacement? You well know that it could be aseptic loosening or osteolysis, infection, hypersensitivity reactions such as lymphadenopathy, autoimmune or delayed response, development of a pseudotumor, which could be because of accumulation of polyethylene and cement debris resulting in a space-occupying lesion or a pseudotumor, and finally, question mark, tumor development status post-implant. Here is a case of aseptic loosening with osteolysis. I think you know better than me as a radiologist or as a surgeon. Here is a case of osteolysis. This is what a cemented prosthesis looks like. We retrieve these specimens and look at them grossly as well as microscopically. So here you see that there is cement here, it has a shaggy appearance to it, and we split this prosthesis area to show you the bed of the cement and bone, and then this one of course is metal, femoral head and stem, and a plastic acetabular component. And the non-cemented, I don't know how many of you look at these things carefully, but here you see in the non-cemented, this porosity was one of the factors that it was started to be used so that there was ingrowth. So this is the bone that is growing into it. This is on scanning electron microscopy where you see the stem, and these are these balls that you see, so that in between you see that there is growth of bone, and so for some time this was very popular. This is to show you a cemented prosthesis where you have this stem, cement around it, and when you take off the sleeve of cement, you see that there is a cavitation. This is cement sitting outside. And finally, here's a cross section, hematoxylin eosin, to show you this smooth fibrous lining. Then there is a bit of reactive tissue with plasma cells, lymphocytes, and finally reactive bone formation. So bone and this is the zone where the loosening is taking place. Very quickly, I want to draw your attention, and I don't know how many of you see your cases microscopically or even grossly. Here you see that this field of hematoxylin eosin soft tissue is very eosinophilic, very cellular. There are gaps, there are holes in it. Again over here, it seems to contain some amorphous material. You look here, there are long bits of shards of something sitting in this space. And finally here, you see that there is a cystic space containing this barium sulfate, foreign body giant cell reaction, and pink large histiocytes evoking a tremendous cellular reaction to this material that you have brought into this person's joint. This is scanning electron microscopy. Maybe there's too much basic pathology, but I just can't resist. I have to show you that we do all these things. They're not exotic. They're a matter of routine at my institution. So we do scanning electron microscopy, and then we finally look at the histologic section of this cement. And here you see that there are these balls of cement with foreign body giant cell reaction. Moving on to polyethylene, you are quite well learned about the acetabulum cup. Then the polyethylene insert, the metal femoral head, and the femoral stem. Every implant that is removed at our institution has to, by law, be submitted to the Department of Pathology. We examine it for burnishing, erosion, etc. And then it is submitted to the Department of Biomechanics, which, as you know, is a leading department in making custom prostheses and trying to learn all the time how can we improve a particular prosthesis. Very quickly to show you the wear damage, this is a good polyethylene tibial insert taken out from the package. And as you see, you can move, and these are the words that we use: scratching, burnishing, pitting, and delamination. And again, the wear debris then causes, it gets ingested, releasing cytokines, osteoclastic recruitment to remove this debris, and finally resulting in bone destruction. So, as a surgeon, the patient comes to you, your colleague, the rheumatologist or the clinician says that there is a swollen knee. What do we do? So they go in, they aspirate this, and you see this turbid fluid, and you think, is this infection or is this polyethylene debris? So we as pathologists then spin it, and we put it out a drop on a glass slide, and here we see this muck, if you will, and this certainly does not look like infection. It's not polymorphonuclear, or it's not chronic inflammation, and when you polarize it, you see that it's in fact all implant debris, confirming that it was implant material and not infection, and thereby we help you to decide what to do next. This is a very beautiful slide of a synovium, and we do frozen sections at the time that you're operating for determining whether the patient has infection or not, and thereby helping you to continue with or without your surgery. So here's a bit of a synovium, and you see that it's not frond-like like fern, but it is very nodular. It has focal areas of yellow discoloration with areas of hemorrhagic discoloration. Could this be PVNS? But no, it's not pigmented villonodular synovitis, and when you take sections from this specimen, you see a variety of reactions. Here you see that there are lots of histiocytes, giant cells, and I don't know if there are some junior people who could recognize what this is. Can anybody say something? This is an asteroid body, and technically when we were in medical school, an asteroid body was supposed to be the hallmark of sarcoidosis. But we now find that this is a non-specific development, and it can occur, and this case actually is just loaded with small and large shards of polyethylene. And when you polarize this on light microscopy, you see it like this, but when you polarize it, you see that there are big and small pieces of polyethylene that have just rapidly been engulfed by this patient's giant cells and histiocytes. This patient had loosening within 3 months of implantation. Moving on to metal, this was a case that we received recently, and here you see that again the femoral head, it's completely burnished, eroded in this region. And here you see the synovium looks very different from what I just showed you. It's absolutely black. It's not gray-black or red-brown as you would see in hemorrhage, such as post-traumatic hemophilia, hemochromatosis, but this is a characteristic appearance of what we see in patients with metal implants, and particularly titanium, not so much so with cobalt, chrome, stainless steel, but with titanium. And my colleagues and I were the first to report this titanium shedding in 1987, Agins et al. At Hospital for Special Surgery, because till then artifact in the lab, but in fact this is what metal looks like on microscopy. And furthermore, you see that it involves not only the soft tissues, you polarize it, it's dot-like as opposed to those linear shards, fibers of polyethylene. And in fact, this is a section of bone, cartilage, and trabeculae. And you see that it also has a propensity to infiltrate because it's an inflammatory response to this foreign material. And higher magnification to demonstrate clearly that these macrophages have engulfed these particles of metal. This is on electron microscopy, how it appears like little Chinese crosses in the endoplasmic reticulum. And to confirm that we were talking sense and not just imagining, we did this special energy dispersive analysis of X-rays, whereby we demonstrated a peak in the titanium. This has become a routine for us, and now we are quite confident when we make this diagnosis. However, every July when our new residents come in, we have a new few small junior attendings, they panic and they start sending frozen one after the other, typically around 6, 7, 8 at night, and we tell them, oh, read our book and you won't do this to us. It's not infection. Moving on to alumina ceramic, then came the phase of the ceramic. And you see that this was the coating, but it has been completely denuded so that it exposes the underlying metal. Here is just to show you some variations, a bit of an impingement in this region resulting in this denudation or removal of the ceramic coating. And here is just in situ. And this is what alumina looks like on microscopy. You can see that there is a tremendous amount of foreign body giant cell reaction, almost looking like a vasculitis. And here is the corrosion product. So then it was thought that maybe we should change this, and people introduced zirconia in 1980. But this is what that looks like also. And you can see there's tremendous of shedding of this punctate, gray, blue, discolored material. We then started looking at lymph nodes, and we found that there were some cases, thank God only a few, that there was systemic lymphadenopathy. And here are cross sections of the lymph nodes. They have this reddish brown discoloration. Microscopically, here you see the germinal center surrounded by the lymphocytes, and when polarized, we could even demonstrate little pinpoint fragments of both polyethylene and metal. So there are a few cases. I have been at Hospital for Special Surgery practicing orthopedic pathology for 30 years, and tremendous amount of material, but fortunately we don't see this lymphadenopathy. And as I will talk about ALVAL, I keep repeatedly asking the surgeon, why don't you submit us some lymph nodes? But they feel that the lymphadenopathy that happens is just hyperplasia. So finally we come to this hot topic of delayed hypersensitivity reaction in metal on metal prosthesis. ALVAL, which is a misnomer, it's an aseptic lymphocytic vasculitis. There is no vasculitis associated lesion, but the name is stuck for some time. And here I was just discussing, and I have been here to India over the past 2 years, 3 years, and I have been exposed to almost 2,000 surgeons. And I'm a little disappointed that the materials are not being sent for examination, which is mandatory in the United States, because you will get a wealth of information to move forward. And I would like to make it a point, this medical tourism has brought many Americans here to be operated all over the country. And of recent, we have seen 5 cases that have come back from here, 4 years, 3 years, 2 years, who have developed this ALVAL, but there was no discussion with the original surgeon. So in this ALVAL total hip replacement, metal on metal, this is what it looks like. You need no introduction. Then there is this surface replacement. We had a Chinese surgeon, and he's well recognized in world literature, Dr. Su, who was gung-ho about this surface replacement till of late, about 1.5 years ago, when we also got more knowledgeable in what we were doing, reading the literature and seeing more and more of these cases, that this also seems to not be such a good idea. So I want to show you, even though you are not pathologists, but I would like to encourage that you send all your materials for the reasons that I'm going to show you in the next few slides. So here is a classic appearance of ALVAL. You see this thick membrane-like material. So in this region, and I'm going to show you higher magnifications, this is pink eosinophilic necrotic tissue mixed with fibrin. As you move down, you see that there is more blue element to it, and further down when you move here, you see a lot of blue cells. Higher magnification, moving from the top to the bottom, you see that there is this fibrinous exudate, necrotic cells. As you come here, you see that there are lymphocytes intermixed with blood. Higher magnification to show you that these lymphocytes carry something in it, and finally, you see that these histiocytes have this globular, pale structures within it, and these are all the metallic corrosion products that are resulting in this hypersensitivity reaction ALVAL. Now, over the past 4 years, we are 4 pathologists, including the chairman. We have collected close to 200 cases at our institution, and we have analyzed these. We are still sitting on it. As you know, in the New York Times front page, about 2 weeks ago, Johnson & Johnson is scared out of its wits because of this, just the surface replacement, $4 billion suit and many more to come. So, in summary, the histological scoring criteria of ALVAL is this. I don't have time to go over it, but if anybody is interested, we can talk about it. Also, at my institution, we do a tremendous amount of immunoperoxidase, immunologic studies of trying to identify B cells and T cells and giving it a score, so that if it's a score of 8 to 10, the patient definitely has severe immunologic hypersensitivity reaction, and you better look for something else. So the changes in the design started around 2004. All the major manufacturers introduced similar modifications to the implants. They tried to make larger heads, reducing the dislocation, shorter trunnion connections, reduction in impingement, adding metallic adapters of different shape, cylindrical or circular, trapezoidal, and removal of the trunnions with a variety of angles. This is my colleague who is a crazy Italian, but I'm very grateful to him because he stays from 7 in the morning till midnight. My hours are much shorter, about 10. And here you see that there is a tremendous permutation combination of shape, size, trunnion, and material. So I don't know where we are going. But if you don't examine the histology, how would you know what really is happening? So in resurfacing, you know that the materials involved are metals, cement, corrosion products, total hip replacements, metals, polyethylene, ceramic, hydroxyapatite, and corrosion products. We tried to study the blood vessel levels of metallic ions. It was not so good. It was hypersensitive, small particles, but beyond that, it didn't really give us a good correlation. Lot of expense. So yes, this looks like a very busy slide, but we have a schematic way of looking at it very systematically. We get the fresh tissue, we keep some for frozen section, we take for electron microscopy, then we put it in formalin fixation the usual way, and we go through whole this slew of doing light microscopy, immunoperoxidase, immunologic studies, in fact going all the way to fish, laser, capture, and mass spectroscopy. Now I don't expect you to do all of it, but as I have spoken to Dr. Maria and to Dr. Raja Sekran and many others, Dr. Sanjeti, many other very eminent orthopedic surgeons, we would love to do collaborative work. And India is my country. I would even volunteer to say on behalf of my chairman, Dr. Michael Klein, that some of it in the initial phases we could even absorb the cost, but you need to send us the material and we'd be happy to work with you on any of these things. Very quickly, just to show you silicon, which I don't know if it's being used here or not, and of course in the United States also it's not. You see that there is a big cystic space, silastic introduction, and here you see the removed implant in a case of rheumatoid arthritis. And here you see that there is a tremendous amount of foreign body giant cell reaction, very different to this material which has a buff appearance to it. It does not polarize, and this in fact is silicon. Again, in the bone you see the same kind of appearance, buff colored material, foreign body giant cell reaction, reactive bone formation, electron microscopy, and finally again the EDAX to demonstrate a peak in silica ruling out everything else. Let's talk about infections, another complication around joints, total joints. We get these all the time because we primarily get a lot, we are the tertiary center. So we get a lot of patients from outside, and just from my point of view, you must send cultures, and don't just put a swab and send it in the broth and send it back. Send actual tissue from wherever you are suspecting. So we do microbiology, we do a frozen section, we do permanent sections, and we put it all together for you to tell you whether there is infection or not. Again, same tube you may say, yes, but do we know, is this implant debris or is this infection? And in this particular case, when you smeared out the fluid, you see that it, in fact, it is very cellular, necrotic material, fibrin, blood, and these are all acute polymorphonuclear cells, confirming that this time it is infection. This is a gross photomicrograph of a knee. You see the extrusion of the cement and very yellow looking pussy kind of material. Made smears, made slides, and confirmed the diagnosis that it's acute infection, and thereby stopping your surgery, waiting for 6 weeks of antibiotics, and then moving on. Now, the next topic is pseudotumor, which results in a large lytic lesion due to the accumulation of polyethylene and cement. Here is a cross-section of the gross. You see the acetabular roof. You see that there is this huge lesion right here. On sectioning and doing H&E, you see that it is a cystic space filled in with this amorphous material. And that was a case of pseudotumor. Then here is a case of autoimmune reaction. I'm going to rush through this. I presented this at the International Skeletal Society in Washington, D.C. 3 years ago. Here was a case of a patellofemoral prosthesis with malalignment. Section showed that there was this cystic spaces filled with material in it, foreign body giant cells, asteroid bodies. Polarized microscopy showed that it was implant material. So we were very happy and said, okay, fine, this is implant reaction, nothing more. 1 month post revision, you saw this little bit of erosions here, and 7 months later you saw that there was marked erosions at the periphery. MRI at 7 months post revision showed that actually the pathology had exceeded, and when a section was taken from that synovium, we saw that there were these huge areas of granulomatous reaction, lymphocytes all around. Here you see that there are giant cells with C cells around the periphery, a nice granuloma in this region, and some more over there. So the question was, there's an enlargement of the lymph node. They took it to Memorial Sloan Kettering thinking that this patient had developed lymphoma, when in fact these were all non-necrotizing granulomas consistent with sarcoidosis. So the question is this sarcoidosis induced by the wear debris or from a failed knee prosthesis, or was there unrecognized underlying sarcoidosis that caused sarcoid-like granulomas around particle debris? So this was not a typical case, but it was chicken or the egg, and we till today don't know what came first. The late complication finally could be development of malignant tumors, primary or secondary to implant, and here you see this was about a 58-year-old woman who had run-of-the-mill osteoarthritis. You can see she had an implant. And a few years later, she complained of pain in a suburban hospital, and the radiologist said, oh, it's nothing. He did an MRI, he did a plain X-ray and a CT scan, and he said, nothing, go home. The treating physician said, take NSAIDs and you'll be all right, and you put your leg up here and there and it'll be fine. Finally, she was not satisfied. The pain became excruciating, and she reported to Hospital for Special Surgery to our tumor surgeon. And when he took an X-ray, he saw that this implant was well in position, there was no loosening, but there were these typical radiation spicules radiating from this, making the diagnosis of osteogenic sarcoma. The tumor was removed at our institution. I took a photograph of the specimen, and you can see that the cortex disappears towards the femoral head. It's completely destroyed. It's replaced by this tumor mass that has a yellow, gray, blue, red hemorrhagic areas with spicules characteristic of radiation, radiating spicules, as you see in osteogenic sarcoma. This was a fixed specimen, and then we also do specimen radiographs, again to show you the spiculation, sunburst appearance, and finally microscopically I think you can recognize also these trabeculae have a stucco appearance of osteoid production, higher magnification to show you that in fact this was all osteoid like here. So host bone, tumor bone, and very cellular malignant cells, making this a diagnosis of osteogenic sarcoma in a case of status post implant. We published this case, but again we could not document whether this was what came first. So in conclusion, the study of retrieved material from revision arthroplasties is helpful in determining the cause of failure, finding better materials for future implants with greater longevity and fewer complications, both at the pathological level as well as biomechanics. And so I would like to end this lecture by saying that all retrieved tissue must be sent for histopathological evaluation for you as a surgeon to go forward. Maybe I'm using big words, but we feel very strongly on this issue, and I hope that my lecture has shown you the reason why you should send this material. These are a whole lot of references. This is the Hospital for Special Surgery, this is my faculty, and we work very closely with the Department of Radiology and Biomechanics. There is the asteroid body, the SIN whisk, and finally, thank you.
Thank you so much, Dr. Bansal. That was really a current hot topic, and I think the importance cannot be overemphasized. And I do wish that this message goes far, that pathology has to be studied, because we have not yet found a perfect implant which can be put in without fear. I mean, I worry if I have to have an implant because I don't know which one.
Yes.
Thank you so much. We're very grateful for you having come all the way from US Hospital from Special Surgery. Thank you, Dr. Bansal.
Thank you.
Thank you.
Dhir Kumar to give the conference lecture. As you know, this conference, we have just 6 conference lectures. There are special lectures throughout the conference, and we invite very prominent people to deliver these lectures. And Dr. Kumar, as you know, is the editor of Indian Journal of Orthopedics. He is also professor and head of the department at University College of Medical Sciences in New Delhi. He is a keen researcher. I think there are several, his main area of interest has been spinal tuberculosis and a basic research, including bone banking. He has several postgraduates have passed under him. He is a regular PG examiner for DNB and MS exams. We welcome you, sir, and we are looking forward to your lecture.
Thank you so much. I must, at the very outset, thank Mr. President and the Secretary for asking me to deliver this talk. I am going to talk on a procedure known as glenoplasty in recurrent anterior dislocation of shoulder. You see, the dislocation of shoulder can be very well recognized clinically with abduction, external rotation, the patient that presents to you in a very typical form in the casualty. However, at times we do get posterior dislocation of shoulder, and any patient who is coming in the emergency with an injury to the shoulder, all the movements must be examined, and if the patient cannot perform an external rotation at the shoulder, you must suspect posterior dislocation of the shoulder and take appropriate radiological investigation to not to miss the posterior dislocation, which at most of the time is missed in the casualty. Shoulder has got a stability because of the static and the dynamic stabilizers. Joint capsule, the glenohumeral ligament, labrum, and the glenoid fossa form static stabilizers, while the dynamic stabilizers is done by the rotator cuff, the long head of the bicep, and the scapular, periscapular muscles. If we go on to the morbid anatomy of the shoulder, the three important ligaments, which are the superior, middle, and the inferior ligament, glenohumeral ligament, which are blended with the capsule and were blended with the glenoid very strongly. It is said that the anterior glenoid and the labrum, they form a very strong bonding, and the strength is said to be about 13 kilogram in males at birth, while it increases with age to about 64 kilograms by 30 years, while it is said to be 30% less in females. However, you get less of this dislocation in the females than in males. The labrum definitely forms a buttress or a wedge around the minimally concave glenoid, and it in fact deepens the glenoid cavity so that the supra-inferior dimensions of the glenoid, they increase to about 30% more than what they are without the labrum. And similarly, it happens in the anteroposterior direction. However, if you have a glenoid which is without the labrum, then you require about 20% less resistance for translation in the anteroposterior or supra-inferior direction. The rotator cuff, they are the fine tuners, and they provide an eccentric control to pull humerus to the glenoid. And the periscapular muscles, they align the glenoid to the joint reaction forces so that to make this shoulder joint move in the most suitable direction. However, this glenohumeral stability can be compromised if the glenoid is small or flat, or if the labrum is torn or avulsed, or if the concavity is lessened by an injury or wear or tear onto the glenoid rim. However, the dysfunction of the scapulothoracic stabilizer can also lead to the instability of the shoulder. There are classical lesions, anatomical lesions that have been described in the shoulder, and on this basis, it is said that the shoulder which gets primarily dislocated in a younger group is almost going to be 100% recurrent in the future to come. In a study by Rowe, somewhere back in 1956, that he demonstrated on a collection of about 321 patients, that almost all those shoulders which are primarily dislocated below the age of 20 years are almost going to become recurrent 100%. But however, a recent study that has been published by Hovelius from Scandinavia recently in 2008, a prospective study between an age group of 12 to 40 years on 229 shoulder over a follow-up of 25 years have demonstrated that 50% of these shoulders who primarily dislocated had no recurrence or had become stable over a period of time. Hence, we have to take with a pinch of salt that every primary dislocator becomes a recurrent dislocator in the younger age group. However, arthroscopy has given us an insight into certain lesions which were otherwise earlier not recognized. This dislocation of the shoulder have been classified according to the degree, the direction, and most of the dislocations that become recurrent are usually bidirectional, either antero-inferior or posto-inferior. However, they could also be classified with their etiology of traumatic, atraumatic, congenital, or neuromuscular in origin. They could also be volitional, either voluntary or involuntary. Who is ultimately at risk? Still, it's said that teenagers or early 20s, those people who early return to competitive sports on a high demand shoulder, or those who have a poor compliance with rehabilitation, or those people who get capsulolabral avulsion, or get an avulsion fracture of the glenoid rim, or have a big, large Hill-Sachs lesion more than about 25 to 30%. The evaluation of these shoulders is based primarily on a careful history and a physical examination of the stability, and other than the x-rays, at times you do require certain other special investigations. However, whether the humeral head is seated well in glenoid or not, this is what the x-ray is going to tell us, or if there is a major glenoid osseous defect, inferiorly or posteriorly, it may be at times difficult to recognize on a plain x-ray, and however, the major humeral defect can be recognized very well on a usual x-ray in various positions of the shoulder, in external rotation or internal rotation, or even in the axillary view. However, there are certain other anterior oblique view which can be taken for showing the glenoid of the scapula. Under certain circumstances, additional information may be desired regarding the capsular and labral tissue, the bone, the rotator cuff, or the neurological status of the muscle. In such cases, the additional tests such as magnetic resonance imaging or a computed tomography and at times electron micrography may be of diagnostic help, and arthroscopy could be also done to understand the Bankart lesion in these patients. However, CT shows the morphology of the anteroinferior glenoid rim, and MRI is mainly showing us a soft tissue definition. The typical lesion onto the avulsion of the anterior glenoid rim in the CT scan, and at CT scan also tells us the dimensions of the glenoid. In repeated dislocation, it can be, however, elicited that what you get is a constant erosion onto the anterior glenoid rim, thereby reducing the anteroposterior diameter of the glenoid in the anteroinferior position. And MRI does tell us about the anterior glenoid avulsion or a typical Bankart lesion. However, we have carried out a non-anatomical procedure for repeated anterior dislocation of the shoulder, and with the basic objective that we wanted to evaluate a surgical technique for these shoulders in which we could preserve the movements of the shoulder in all direction, and this being an extra capsular procedure. Because most of these procedures, anatomic or non-anatomic, for traumatic anterior dislocation of shoulder have shown variable degree of restriction of shoulder movement. Basically, this procedure involves identifying the infraglenoid tubercle and making an osteotomy onto the neck of the glenoid right from 6 o'clock position on the right shoulder up to 2 o'clock position anteriorly and 10 o'clock position posteriorly. And then a graft is inserted in this osteotomy site so that the graft is holding on to the is projecting anteriorly to about 10 millimeter and inferiorly to about 6 millimeter. And we had done about 102 patients during this period, and between the age group of 9 to 40 years, we had 4 females and 98 males, while the number of dislocations that we had varied from 3 to 24 with a mean of 9.4. The criteria of selection has been simple: any dislocation which is more than 3 times, and those patients who had epilepsy or addiction to drug or had atraumatic dislocations were excluded in this study. The surgical steps are just being shown here, that you have to you take the arm by the side of the chest, identify the anterior axillary fold, abduct the shoulder to roughly around 80 degrees, and this mark is being extending right up the posterior axillary fold, and posterior 2/3 of this is taken as incision in the axillary region. The underlying tissues are undermined by a finger dissection, and then the inferior tubercle is being identified, and from that the osteotomy is done. And the osteotomy is prised open, and the graft which is taken from the iliac crest, measuring about 3 centimeter to 2 centimeter into 1 centimeter is pushed into the osteotomy site. It's right pushed into the osteotomy site, and then the osteotome is withdrawn, and the graft is very well placed. It gets placed in the osteotomy site, and it gets compressed by the osteotomy itself. And that is what it looks like after the operation is complete, and the post-operative x-rays. If I could show you a operative step right here, if this works. No, it doesn't work. Okay. If it doesn't work, it's all right. Now, this is what the osteotomy looks like, and the graft is being projected anteriorly to roughly around 10 millimeter and inferiorly to about 6 millimeter. After post-operatively, this immobilization of the shoulder is done in flexion, adduction, and internal rotation for a period of 3 weeks. And after 3 weeks, the graduated exercises, the pendular and overhead exercises are started, so that the full movements are regained within 12 weeks. These grafts got completely incorporated in all these patients, and we had superficial infection in about 3. Till date, we didn't have any arthrosis, and there was no redislocations. The patients have been followed up about 2 to 20 years with a mean of about 6.5. Now, whole idea is to get back a glenohumeral rhythm. If I could get the video right here. No, it doesn't work. The video is not working. Anyway, is it working? No. Okay. So whole idea is to get back the glenohumeral rhythm in these patients, and all of our patients had a very good glenohumeral rhythm, and they were estimated with the modified raw score, and Majority of these patients had a very excellent result, and about 9 cases had good results. This is just to show you the movements of the shoulder in a patient who was a boxer. He had an excellent overhead abduction, external rotation, and internal rotation. Another patient who was a medical student had a dislocation on the left side, and he was a left dominant hand, and he had a full function. And this is how the X-ray looks like in a follow-up of about 10 years. The graft gets also remodeled as the function determines the form. And this is a young girl who was about 9 years old, used to dislocate her shoulder, following a fall, and she had dislocated. She had dislocation about 4 times before she came to us. And we have done this in the youngest. She's one of our youngest patients and had a full function back. This is another patient, an anesthetic technician at our place, also involved in heavy work in the CSSD. And this fellow used to have dislocation about 15 times. And this fellow is now, you can see the full range of motion that he got, and in a follow-up of roughly around 20 years now, and he has got a full range of motion with an excellent glenohumeral rhythm. This is what happened after 15 years on this. The graft possibly has remodeled, but you could see the graft which is still projecting inferiorly and part of it possibly anteriorly. And this is another one which is showing a follow-up of 22 years. The graft can be observed, part of it can be observed on the anterior aspect and the anterior aspect and the inferior aspect right here. What we feel is that there is some change in the glenoid inclination when we carry on to this osteotomy. The cadaveric study has shown us that there is a glenoid inclination in a population about 5 to 10 degrees. While when we carry out this osteotomy, the glenoid inclination possibly increases to about 20 degrees. And this may be one of the possible contributing factor which actually produces the stability onto the shoulder. So hence, to end this, I must say that this procedure has given us an advantage, as it being extracapsular technique, and no blood transfusion is required, no metallic fixation is required, and the patient gets full motion and strength, and it possibly works by a redirectional osteotomy, and a deficiency of the labrum gets supported anteroinferiorly on this graft, and possibly the increase in the inclination of the glenoid results in a dynamic stabilization of the shoulder. In the end, I must pay my regards to my teacher, Professor Tuli, who has in fact taught this procedure to us. Thank you so much.
Thank you, sir. That's fascinating. Thank you very much. And I can vouch because I have seen this being happening when I was working with you many years ago, 1988-89. It's a fascinating procedure. And it's too simple to believe. Thank you very much, sir. We're very grateful for your presentations.
Thank you,
sir. Thank you.
Now we invite Professor K.G. Gopalakrishnan to give an oration on M. Natarajan eponymous lecture. Dr. Gopalakrishnan, he was formerly head of the department at Government Medical College Trivandrum. Presently, he is, after his retirement, he is working as head of the department at SUT, Academy of Medical Sciences in Trivandrum itself. He has been trained in orthoplasty in Robert Jones Agnes Hospital, Oswestry. His main areas of interest are orthoplasty, oncology and teaching. He is a very well-known teacher and a PG examiner in southern part of India. We welcome you, sir.
Very good afternoon to you all. Respected chairpersons, President of the Indian Orthopedic Association, S.K.S. Maria, Honorable Secretary, Sudhir Kapoor. Even though I'm quite used to be taking a challenge of giving a lecture without any preparation, it came as a so surprise that when I left this morning, about 8 o'clock, I was not aware that I would be honored by giving a eponymous lecture this morning. Anyway, I am delighted to be here and I feel honored to be giving a lecture on behalf of the honor of Professor Natarajan. I have two connections with him. I've been to his house several times for enjoying the refreshment of tea as well as the hospitality with my good old friend Mayil Natarajan. So I have great pleasure to be here giving a lecture on his behalf in his honor. Professor Natarajan was born in the year 1920 and has lived as a doyen and teacher of orthopedic surgery in the southern states as well as the whole of India, and he left us in the year 2005. I came to realize that he was working in the Madras Medical College as professor and head of the department for nearly 19 years, from the year 1957 to 1975. He had various fields of interest, not only orthopedics, physical medicine and rehabilitation, and it is proud to know that Madras Medical College has been risen to the postgraduate level with his effort. He only started the MS Orthopedics diploma as well as diploma in physical medicine and rehabilitation. He was responsible for starting the Artificial Limb Center in Tamil Nadu and Madras Medical College. And he has developed not only the Pioneer Institution, but also has been responsible for developing orthopedic facility all over the Tamil Nadu in the district hospital levels. And I have great pleasure to give this lecture on behalf of Professor Natarajan. I was not sure what I should be talking, but I realized that his son, who took up the mantle of his field of interest on tumors affecting the skeleton, he has great interest in bone tumors. I thought that it will be a befitting tribute to him if I take a subject which is closer to his heart, as well as his son Mayil Natarajan. So I will be spending my next few minutes talking about some basic aspects of bone tumors. I'm not sure that those of you who are actually sitting is not familiar with what I am going to be talking about. But as we hear several times, there will be at least one person among the audience who has not been able to make his or her judgment on bone lesion when he is confronted on his own. So I will go down to the level of talking about looking at a bone lesion and how to look at this in an informed manner. I will right away show you these X-rays. This is an X-ray of the lower femur, both sides, and this is the tibia, and can you make up your mind what is the clinical impression about these conditions? Clinical impression, I will put up about 1, 2, 3, 4, 5, 6 X-rays. May be difficult, some problem. While you are thinking about, you and I may be differently thinking about what should be the way to look at an X-ray. I have my own approach, you have your own approach. None of us may be correct approach is actually familiar to us. So diagnosis is always important for a correct management as well as for an informed judgment of follow-up. The first picture is the clinical impression of a 24-year-old female, and the diagnosis was considered to be giant cell tumor. The second picture is of a 21-year-old female and also was considered to be a giant cell tumor. And a 17-year-old female, an upper tibial lesion of that level, that was also clinically diagnosed as a giant cell tumor. 35-year-old woman with a painful proximal radius, and this was considered to be a clinical diagnosis of tuberculosis. This is a very interesting problem. I can't forget about my teacher, Professor K. Venugopalan Nair, the very first day when I joined as a postgraduate student, told